Ehud Ur is the professor of the medicine of University of the British Columbia and the head of the UBC Division of Endocrinology at Vancouver Hospital and St. Paul's in Vancouver, BC. He is a graduate of the University of London and trained in medicine and endocrinology at St. Bartholomew's. Thank you, Bartholomew's Hospital in London. His research interests included neuroendocrinology disorders, diabetes, dyslipidemia, and obesity. Dr. Ur is actively engaging in both laboratory and clinical research and has published over 2,000 papers, chapters, and abstracts in these fields. I'm going to be busy on the computer. Dr. Ur has been an investigator in clinical trials of new agents in diabetes, lipid disorders, Cushing's disease, and obesity. This is Dr. Ur that was supposed to be here this morning, so I could say thank you along with Dr. Johnson for helping me get the support group going. I'd like to welcome Dr. Ur.
So thank you, Deanna. That's a very kind introduction, and I'm actually going to fill in some details because I've got 15 minutes. Is that right? How long?
Yeah.
Yeah. I want to talk about a couple of research trials that we're going to do, and perhaps interest you in. But I'm going to just give you some general background about myself, my thoughts about this meeting, and about acromegaly before I talk about the trials. Deanna, I loved your story, and it was a beautiful tribute beforehand. The only part I don't believe is that you were sitting on a couch, because it takes tremendous energy to do this kind of thing, and I think you're all very lucky to have Deanna as a kind of motivator in organizing this. It really takes that kind of energy to bring out the energy in other people, and it's wonderful to see. It's absolutely wonderful for me personally, because my involvement in acromegaly, I know I look young, but my involvement in acromegaly goes back 40 years, literally 40 years, September 1977. Wow. Some of you were babies, some of you weren't even born then. But that's when I saw my first patient with acromegaly at St. Bartholomew's Hospital. And though you might not know much about BARTs, it is actually instrumental in the development of some of the treatments that you are on now, or some of you have been on. Some of the first patients treated with acromegaly with somatostatin analogs were amongst our patients that we looked after there. So my experience with acromegaly goes back to the late 70s, early 80s, when we had very little in the way of treatments. We had one drug called bromocriptine. Some of you may still be on that, but it's not very good. It's not very effective as a treatment for acromegaly. Of course, we had the surgery, but the surgery was nowhere near as sophisticated as the kind of work that Dr. Acromegaly is doing now. I mean, it literally was quite traumatic, and we didn't have the endoscopes and the brilliant microsurgery that people like Dr. Acromegaly and others are able to do these days. We didn't have even the standard diagnostic machines, the MRIs, CTs were just coming into use, so it was a very, very different world, and it was a different problem in many ways. 20 years ago, I came to Nova Scotia in Canada. Some of you may remember me from Halifax, where I came and was involved in the setting up of the pituitary clinic there. And then I moved to Vancouver, literally again, 10 years ago in September 2007, and I've been involved with care of acromegaly and other clinical problems here. Over that time, I've been involved in several trials of treatments for acromegaly. I've been involved in developing national and international guidelines for the treatment of acromegaly. And of course, I've seen a lot of patients with this relatively unusual problem. And that really brings me to this meeting, which I think is in many ways unique and wonderful. we're living in a strange era with regards to information. Some of you may have noticed that you know more about acromegaly than your doctors, right? You know that. It's a very awkward situation for many people, and there's several reasons for this. The first is that acromegaly is a rare disease, and most physicians have not only not heard about it, not seen it, but they've heard very little about it. You know, you can go through medical school without seeing a patient with acromegaly, more than likely. I was very unusual in that the first patient I saw was with acromegaly. Many patients, many physicians have never seen a case. And they certainly don't read up about it on a regular basis. They certainly don't know about the advances. But with the internet, you do. You have access to all that information. And of course, you're highly motivated to find out about this information. And that sets up a certain tension, and that is a problem. We also know from bad experience that outcomes in the treatment of acromegaly and similar problems are best when handled in a specialist center. We know that. We know that from studies that have been done that have shown that. And in a system of healthcare like Canada's, where many people live in remote locations where they don't necessarily have immediate access to specialized expertise, with a big geographical footprint that we have in this country, that generates another problem. And so I think the opportunity for you guys to get together and to share information and to share strategies and experience is so powerful on so many levels. It's empowerment, it's a self-empowerment that I think is to be encouraged and supported and to be honest, to be in awe of, to see the patient power of people taking charge of the management of their conditions is a very, very powerful thing for somebody like me to see. It may be threatening for people that don't understand or don't have a good knowledge of acromegaly, but for us, the experts in acromegaly, it is something that is very, very positive. Now, the treatments that we have today, some of them are good, some of them are not as good, but certainly there's an advance on what we had when I first saw acromegaly 40 years ago. Those treatments have been arrived at through research. Research, it sounds like a fairly ethereal thing to many people. It doesn't seem to have practical applications. When they hear the word research, they think of people beavering away in labs and doing stuff that doesn't necessarily apply to anybody. This really applies to you, and you know it. You know why it applies to you. And so the advances that have been made in the treatments that you get today have been through the research that we've been doing over these last 40 years or so. And I think that also is something that can be encouraged through the communications in a group like this. Now, we've got two studies that we're currently doing, or are just about to start. And before I talk about the studies, I'm just going to introduce our study coordinator, Jack Bondi, who's going to stand up here. And if you personally have any, remember, there's no obligation on anybody's part to take part in these studies. If you have an interest, or you know somebody that might be interested in one of these studies, then please just contact Jack. And remember that even expressing an interest doesn't mean that we're going to jump on you and give you experimental drugs. Okay, so these are the two studies. The first is a study called Optimal, and that's the one that's up here. Optimal is, like many of these studies, is an acronym for octreotide capsule versus placebo treatment in multinational centers. And essentially what this is, I'm not going to do a show of hands because I don't want to put anybody in any awkward situation, but many of you will be on octreotide, I'm sure, in one form or another. And as you know, it's via injection, and you probably think, oh God, it's a real pain to have an injection once a month. Well, I can tell you when octreotide first came out, I don't know if anybody here is old enough to remember that, but when octreotide first came out, it was an injection that needed to be given 3 times a day. So the once a month version that you're having is certainly an advance on those previous therapies. But wouldn't it be nice if instead of taking an injection, you could just have a tablet? Why isn't it a tablet in the first place? Well, because octreotide is a protein, and if you swallowed it, it would be broken down and basically digested. That's why proteins like insulin and other hormone therapies need to be given by injection. And so this is a study of special capsules that allow the octreotide to be absorbed without being broken down. It's not a study that involves a new drug. It's just a new delivery system for an old drug, the micronized octreotide. The inclusion criteria for this study, I will just go through. You have to be over 18 years of age. I suspect everyone complies with that. We require you to have received octreotide. SRL stands for somatostatin receptor ligand therapy. It's a fancy way of including two mainly, agents that are used for this purpose. And you need to have been on either sandostatin or lanreotide for at least 6 months with stable dosage for the last 3 months. You need to have an IGF-1 average level of below the upper limit of normal for the past 2 screening assessments. So you essentially need to be under control on current octreotide. And obviously you have to have acromegaly as defined by evidence of growth hormone secreting pituitary tumor in the past and a pathology report, and evidence at some point that you had elevated IGF-1 levels. In terms of exclusion, the people that we can't include in this study are surgery of the pituitary gland 6 months prior to the screening, so you can't be a recent recruit to the world of acromegaly. You can't have diabetes. Some people struggle with that additional problem. And there are some specific biochemical tests around liver function that need to be normal. And if you've participated in any of the previous trials involving this agent, which I suspect none of you have. So that's this study, and certainly anything that makes it easier for you in terms of the burden of the disease that you have to handle is to be encouraged, and I certainly appreciate anybody who is able to assist us with that. The other study is another concept altogether, and this is called strict IGF-1, and it's about control in acromegaly. And this goes back to a whole other issue, and that is what's normal, okay? Now, in the old days, the tumor was removed, the tumor being the source of the elevated growth hormone, and pretty well that was it. We recognized that some people were still symptomatic if they had an elevated growth hormone or elevated IGF-1 after surgery. But there certainly wasn't the concept of aggressive therapy, not least because we didn't actually have the ability to measure IGF-1. Nowadays, of course, we have that, and we also have multiple epidemiological studies. And what I mean by that is people followed over a period of time to see what different levels of growth hormone activity translate to in terms of disease and life expectancy and so on. And what we do know from these studies is that even modest elevations in growth hormone and IGF-1 are not good news for your general well-being and your general life expectancy. We don't know exactly what the target should be. So what we're going to do in this study is look at whether strict normalization of elevated IGF-1 levels can result in clinical benefits in patients with acromegaly who've had a partial response to somatostatin agonist therapy and or suboptimal dose of pegvisomant, which is another kind of drug, in combination with somatostatin therapy. I should point out that the first study was sponsored by a couple of drug companies. This is a study that's been initiated by our research colleagues around the country and led out of St. Michael's Hospital in Toronto. And in this study, you simply have to have acromegaly over the age of 18, been on monotherapy, in other words, just somatostatin analog therapy on its own, or in combination with suboptimal dosing of pegvisomant. In other words, you've either not been on pegvisomant or you've got room to go up on a higher dose of pegvisomant for at least 6 months. showing IGF levels that are between 1 to 1.3, the upper limit of normal. In other words, if you're more than 1.3 times the upper limit of normal, we know there's a problem, and so that needs to be treated, so we couldn't really include you in a study. So what we're looking at are people who have slightly off control, whose IGFs are just a little bit higher than they should be based on the normalization tables. And what we want to see is whether that normalizing the IGF-1 in these individuals actually brings things back to normal in terms of their overall health. In terms of exclusions here, the people that can't participate are people, again, who have significant liver problems, patients who have received either pituitary surgery or radiation within 1 year of the study. So you need to be at least 1 year post-surgery or radiotherapy. If you've had a hypersensitivity to pigvisomant, had a problem with that drug because that's an essential component of this study. And then if you've had problems with cranial nerves or intracranial hypertension requiring tumor decompression surgery, that's a very specific problem that most people wouldn't have had. And if you are known or suspected to have a problem with alcohol or drug abuse. What's the definition of an alcoholic? Somebody that drinks more than their doctor. So as I said, if you have any questions or if you're interested in this, this is Jack's email. This is Jack, or you can come to me. If you have any questions about any of these two studies, or if you have any questions